Hi, my name is Frank Lunetta, and I did a research study on the effects of prolonged exposure therapy on a veteran's PTSD severity and symptomatology. And so, in introducing the subject, I worked with a man who, under the pseudonym of Joe, we'll call him, who was a 37-year-old Air Force veteran. He worked in the Air Force for 10 years as a drone pilot, working in a room similar to this, very isolated, seeing a lot of traumatic events, seeing death, being responsible for the actions as well. He wasn't diagnosed with PTSD until he was around 34, due to fears around losing security clearances, losing his job, and just not wanting to admit his struggles. But it's PTSD has been something he believes he's been dealing with for around 10 years, or for around 5 years of his career in the military, but just didn't want to admit it. He's tried presence-centered therapy. He's tried other forms of psychotherapy, but it hasn't worked. So he's agreed to do a 10-week AB single subject design study involving the effects of prolonged exposure therapy on his PTSD and some of his symptoms. We focused on four main symptoms: unwanted memories, avoidance of stimuli, um, uh, difficulty sleeping, and exaggerated self-blame, and that is in conjunction with the overall PTSD severity. So we wanted to see, measuring using the PTSD checklist for the DSM-5, if prolonged exposure therapy would have any sort of impact on reducing overall PTSD severity and those four main symptoms. So in our introduction, prolonged exposure therapy is a form of CBT which focuses on dealing with avoidance, facing memories, and putting yourself in stressful situations as a way to challenge PTSD. Due to its structure, PTSD has been really effective in addressing avoidance and has been really important in utilizing and benefiting combat veterans, but it really hasn't been used to focus on drone pilots in particular, and there are limited studies on that population. It's a really important thing. Focusing on PTSD is really important due to the amount of people in the war in Iraq and recently who went to war who have PTSD, which is around 29%, which is even a lot higher than previous wars. So PTSD rates seem to be a major concern for veterans, and for any wars in the future will be a concern for addressing. I would say I have limited professional experience with this type of therapy. I've begun to use sort of tenets and ideas and breathing retraining that I'll mention later in my own work. So I've kind of had extensive experience with sort of tenets and certain factors involved with prolonged exposure therapy. The goals and objectives. The treatment goal is to reduce Joe's overall PTSD severity while also reducing symptom severity of the four symptoms I mentioned earlier. The objectives are Joe will seek to develop coping mechanisms. Objective 2 Joe will be able to challenge avoidance to specific stimuli they had. Specifically red lights, small spaces, even video games can be kind of triggering for him just because the feeling of that joystick can sometimes be a real trigger for him. And then Joe will directly challenge his traumatic event and multiple traumatic events that really impacted him. But we're going to focus on one traumatic event in particular. And then next slide. So now going over the psychosocial mental health problem requiring intervention. So for the PTSD criteria, I just wanted to put it out there so you could see what it looks like. We're not going to go over every sort of criteria. I just want to go over, first of all, someone who is diagnosed with PTSD has to be exposed to some sort of threat, death, life-altering experience that's related to trauma, and trauma is best described as an emotional response to a terrible event like an accident, crime, again, some sort of death. And so we're going to focus primarily on criteria B, C, D, and E. And these criteria focus on the different types of symptoms. And we're going to focus on one symptom from each criteria. So for criteria B, traumatic events we experience. Criteria C deals with avoidance. D is on negative thoughts or feelings, and criteria is arousal. And I'll explain those symptoms that we focus on in the next two slides. So for Joe, he is a 37-year-old white male from South Carolina, middle class, works for the VA, currently furthering his education. So kind of having a biopsychosocial assessment. He has no family history of PTSD or other mental health related disorders, specifically related to trauma at least. He has a history of insomnia that actually started before he developed PTSD, which is worth noting. And he still has nightmares related to PTSD. The psychological aspect of himself, he experienced trauma related to violence and death over a 10-year career, so this is something that he experienced every day. He has emotional outbursts 4 times a week. He has triggers related to violent video games, enclosed spaces, red lights. He experienced moral injury from the families that he kind of actually felt connected to, and I noticed the psychological connection below. He really felt that he was doing something immoral and what he was doing was wrong, because a lot of these families that he would develop connections to, he didn't notice the threat. There was also a general noticeable lack of psychological coping skills that he has in his life. Socially, in looking at this part, I just noticed that he was undiagnosed out of fear of losing job. There's a military culture that does not emphasize mental health treatment. There's also an accessibility problem socially when it comes to VA healthcare. He has a real negative history related to VA healthcare, kind of not only having them deny his benefits, but also struggles with the VA in general. And so for the psychosocial mental health problem, I wanted to focus on how it applies to Joe, and I kind of talk about symptomatology as like the study of symptoms and what symptoms are and expressed when it comes to PTSD. And so here I kind of put it clearly. I just want to note Joe was diagnosed first with the CAPS PTSD scale, and then it was reconfirmed with the PTSD checklist for DSM-5. He's tried things like EMDR and PCT, and he experiences around 4 trauma responses per week. Most trauma responses are tend to be caused by these 4 symptoms. The first one is unwanted memories that we're going to focus on. Oftentimes, when he gets reminded of families or see families enjoying and having fun, he's kind of reminded of the lives he took and the families he kind of broke apart at his job. Avoidance of trigger and stimuli. He tends to avoid video games, small spaces, anything that makes him feel cramped, and so that trigger tends to pop up weirdly a lot in his life, as well as like dark rooms kind of bring him back to that small space that we saw earlier. He has exaggerated self-blame. He really thinks he could have stopped the war, he could have stopped the death, and yes, maybe he could have quit his job, but there would have been consequences with that. And there's a real exaggerated self-blame that you see in Joe in particular. And then the last one that we're going to focus on is sleep difficulty. He's constantly being jolted awake, as he describes it. He can only sleep 2 to 3 hours a day, and he says it's somewhat related to his nightmares, and those sleep difficulties really pop up in this way. And these are what he describes as the 4 main symptoms to focus on and that he wants to address in this work. So our hypothesis, already somewhat mentioned, the goal is to see if PE effectively reduces individual PTSD-related symptom severity, and we believe that through the current study that PTSD severity by the end of the treatment will have a decreased compared to a baseline measurement. So we believe that as he goes through PE, there'll be a noticeable decrease in PTSD severity. In terms of PTSD-related symptomatology, the researchers hypothesized that all 4 aforementioned symptoms will have a significant decrease in overall severity. Okay, and then so that's the hypothesis we're kind of working through. And then the single subject design approach, the study used a A-B single subject design. It had 2 phases, A, baseline, no intervention, 4 weeks of measuring a baseline, B, intervention phase. And the current study made sure to get an initial baseline measure to see if there's a clear changes in PTSD severity and symptomatology during treatment. I have a little experience with this sort of work in my undergrad doing mock trials related to A/B single subject designs, so I was really comfortable with it. The strengths of the design, since the study is A/B design, it allows for the full length of the treatment. The lack of any sort of withdrawal or removal kind of leads to his highest chance of getting the benefits of the treatment, and that was just important with Joe, considering a lot of these psychotherapies have failed in the past. We didn't really want to put him in a position where he might want to drop out because he's not really getting that support needed. Its logical empirical impact of an intervention, it shows like within that span what was the impact, and it's pretty clear, especially when you're doing a week by week measurement. And it's easier to implement compared to other single subject design. It's also easier to get on board because it's just like you're giving him the whole treatment. And in general, I think there's also just less ethical concerns with this design. to go over kind of the weaknesses of the design, there's real threats to internal validity in this approach that we have to worry about. It does not control for extraneous events or outlier data, which is really important to note. Because there's that lack of control or kind of withdrawing and showing it again. So there's that lack of replication within the study to show, hey, did this actually cause that? As a result, it's kind of weaker in terms of controlling history. It can cause problems with generalizability as well in terms of single subject design, because again, it's only measuring that 10-week stretch, so it might be hard to generalize. And there's again a lack of long-term study on the lack of impact long-term on the client, noting that there's no like clear follow-up or focus on a follow-up, so you're not really sure, hey, is P going to have long-term impact? It's worth noting that there's evidence in the literature that P does have long-term impact, so that's kind of why we didn't focus on it in this particular study. As mentioned, I think there's limited ethical concerns related to this design, but it's worth noting some. Waiting weeks prior to provide care, again, limited ethical concern, but maybe taking that baseline for 4 weeks, it could have made a difference, or like doing it as soon as possible. It's just something to consider. Patient also just might feel pressure to complete treatment. He's the only subject we're doing the work on, but again, it's for his embetterment. It's to better himself and to address PTSD symptoms. So it is just something to worry about, that there's a lot of pressure on him, and there just he might not want to show a reduction of symptoms. I think there's always an ethical concern working with veterans. They are the population that tends to be exploited the most. And he might be concerned about things related to disability benefits, or just really feel uncomfortable in kind of these high stress situations that are going to be put in regards to this study. And now we can focus on the intervention here. It's prolonged exposure therapy. It involves 10 weeks, which is the intervention stage, and a 4-week baseline. Each session during the intervention phase is 90 minutes long. And so for the baseline, weeks 1 to 4, that's the measurement of no interventions given, and treatment, weeks 5 to 14, it measures all 10 sessions of the intervention. And so for prolonged exposure therapy, it's commonly used for social anxiety, phobias, PTSD, and trauma. The theory that underlines it is emotional processing theory, and is believed PTSD occurs as a failure to deal with traumatic memories and due to avoidance of traumatic minders. It is the belief that oftentimes people with PTSD, they develop what's called a pathological fear structure, in which they make associations with things that relate to past trauma. And due to things like avoidance, triggering of that, and then like greater fear that comes with it, it just reinforces itself over time, making it hard to address it. And this theory believes that the only way to address problems related to PTSD is to challenge those fear structures and to challenge those beliefs that you have, that like, if I do this, this is the response I'm going to get. So it's pretty helpful in dealing with avoidance behavior, as mentioned, and it involves direct challenge and confrontation. That is the only way, like that activation is the only way to like truly address the problem people are going through. And so these are the components of prolonged exposure therapy. It's psychoeducation, which is just education about trauma responses, how to deal with it. Breathing retraining, that it just involves different types of breathing techniques like box breathing. There's homework that's given after session, usually given after each session. And in vivo exposure, which is the key component of prolonged exposure therapy, and that's doing sort of, as I mentioned, it's doing exposing yourself to uncomfortable stimuli in a measured way. So you have this different hierarchy, and the exposures and triggers that maybe aren't as hard to deal with or cope with, you would deal with first and kind of work through it out of session, out of therapy, exposing yourself to stressful situations in a meaningful way. There's also imaginal training, which involves imagining the traumatic event with your therapist. This is primarily where a lot of the work during therapy is focused on. It's just imaginal training, going over the trauma, imagining it, and then taking a video of it, recording it, and even replaying it for homework sessions. So a lot of the work for imaginal training is done with the therapist, and that's what most of the sessions are made of. And it's really like reevaluating that traumatic experience you had and like going over that experience again, which can be really hard for a lot of people. So goals and objectives, just to go over quickly again, we believe that like for objective 2 and 3, that's clearly addressed with both in vivo exposure for objective 2 and for challenging traumatic memories, imaginal exposure, it directly challenges those. And then for objective 1, it's you have the psychoeducation, breathing, retraining. So I just wanted to kind of show and bring back the goals and objectives, how the different components of prolonged exposure therapy are addressing those objectives. So for the effectiveness of the intervention, there's a couple. The general finding is it's highly effective in addressing avoidant behavior and negative affect. There's limited evidence so far for sleep. In general, you have in comparison studies from P and PCT, Schnur et al. Found that intrusive memories, avoidance of places and people, detachment and estrangement, and restricted range of affect largely saw a lower retention rate compared to PCT therapy. I think the really important notice of the intervention and why it's effective is that in an initial study done in 2007 that kind of put it to the forefront, it found 15% of female veterans in prolonged exposure therapy went into total remission. And this has really been able to show how it's effective. And like in the next one here, in the next quote, it shows, it has a little better reduction in overall symptoms compared to another type of therapy called CPT. But in general, it's really that total remission that prolonged exposure therapy can offer that really interests a lot of people. And even though it's really challenging, that's kind of why people are so interested in its effectiveness and why people use it also. Some other types of treatment worth mentioning: EMDR, narrative exposure therapy, cognitive reprocessing therapy, and present-centered therapy. EMDR is a pretty new one. It's pretty exciting. People like how a lot of it has to do with eye movement, and it kind of challenges norms around psychotherapy that it has to be focused on necessarily talk therapy, and it takes a different approach. So it's been pretty interesting. Narrative exposure therapy is kind of new to the field, writing narratives of your trauma, and CPT and PCT are different types of cognitive behavioral therapy as well, really focusing on the present moment and processing those experiences. CPT and PE tend to have a little bit of similar focus, except CPT doesn't focus on avoidance. And then medications such as SSRIs, like sertraline, fluoxetine, have been really popular for PTSD, but they're usually in conjunction with one another. Usually, one psychotherapy isn't the cure-all, and one medication isn't the cure-all, just due to the complicated nature of people's struggles. And then clients' values and rationale. Here I put the Air Force core values just so you have an understanding of like what type of person he is and what people in the military tend to value and focus on. And so a real focus of the intervention was trying to find something that was challenging and kind of begged for excellence and like commitment. Being in the military 10 years, he has a strong belief in commitment, kind of relying on someone else. And a lot of the expectation is he will do it at home. He will be responsible for himself, following like the lines of military culture. It was also important that it was challenging. He said the other forms of therapy, they weren't necessarily not challenging, but he felt like it was just talking. There wasn't anything beneficial. He didn't feel a change. And so he really wanted this sort of challenging therapy. Also, the structure. He really thrives off structure, being in the military for so many years. And prolonged exposure therapy tends to be a pretty structured version of therapy. It is also one of the most commonly used forms. He was really important on evidence-based practice and something that has worked, and so that's why we led into it. And also repetition. He was used to repetition, doing the same thing every day, living on a military base. Wasn't much change. PE tends to be from sessions 3 to 9, really repetitive and consistent, and I think that expectation was good for him. Even though you talk about different things, I think the clear expectation that this is what you do and this is kind of the results you would get was the reason why it kind of fit where the client was. Focus on the measurement here. The measurement, it is the PTSD checklist for the DSM-5, otherwise known as PCL-5, which I kind of referred to throughout. The checklist is 20 questions on a 0 to 4 scale from not at all to extremely, and it has each individual symptom of PTSD that's mentioned in the criteria. So for every question, it usually matches to one of the symptoms in the criteria for PTSD, so it's very much connected to the DSM-5, which makes it a really good test to use or measurement to use. A score of 31 to 33 of total symptom severity is considered someone to have PTSD and someone who needs to seek out treatment. And as mentioned, I focus on individual symptoms of unwanted upsetting memories from criteria B, avoidance of trauma-related memories from criteria C, exaggerated blame of self or others from criteria D, and difficulty sleeping, which is related to the criteria E in the DSM-5. This does not fully operationalize the category. I want to make sure to put that out there. It doesn't represent B, C, D, E categories. It's just we wanted to get a full representation of PTSD in the experience. So we picked 4 symptoms from the different categories to kind of encapsulate what the experience is like. So in operationalizing the symptoms, here's a snapshot of what the questions we'd be focusing on. I couldn't fit the whole questionnaire, so I focused on the 4 individual symptoms that we're looking at. Question 1, repeated disturbing memories of question 7. This is for the criteria C. Portion of avoidance for criteria D, we focused on stressful kind of experiences and how that relates to blaming self. And so self-blame is criteria D. So here, I just wanted to show what the operationalized version of it looks like in terms of the individual criteria. So for unwanted memories, you have question 1. For avoiding external reminders, you have question 7, which explains it. For exaggerated self-blame, we have question 10. And for difficulties falling asleep, you have question 20 here. It's important to note that here it mentions in the past week. That's really important to understand why we did our measurement the way we did. We wanted to make sure, at least I wanted to make sure that we got a representation of what the symptoms were like post-session. So that's why we did it before the intervention was given. And that way we could get a sense, hey, what was the impact of session 1 a week later? And so that's why we did it before any intervention, to make sure it's pretty representative of what we're trying to get at here. To understand the validity and reliability of the PCL5, I focused on a major meta-analysis that focused on hundreds of studies regarding the validity and reliability of the PCL5. And it was interesting to find that it had low correlations with measured topics, so it had low discriminant validity. It was kind of expected, especially due in this general finding I put. It was really related to specific PTSD tests like CAPS-5, but those tests that focused on sleep, substance use, guilt, really low in terms of discriminant validity, so it had low correlations with other measures. Convergent validity was strongest correlated, 0.44 to 0.89, and the majority of studies were in that kind of 0.8 range. It really felt it had strong correlations with tests like the CAPS-5 that measured PTSD, and that was important in considering picking it as a measurement. Reliability, it had really high internal consistency, 0.83 to 0.97, which is that's really high in terms of internal consistency. And that's really important when, hey, is what's being asked something that relates to PTSD? Does it fit kind of that construct? So it's really important to consider that. And then the other major, besides the reliability, on the different questions asked, retest reliability, coefficients range from 0.58 to 0.91. And generally, studies are looking for coefficients above 0.6, and with 0.58 being on the lower end, it was really important to note that the more and more someone took that test, they would get the same answer. And it was really common. Most of the tests in that range were in that 0.8 range, and that's really what you're looking for in terms of a reliable test. So in applying the intervention, the duration of time, just to repeat it, is 10 sessions, 90 minutes. The client was seen at 4 p.m. every day. To begin the study, a baseline was taken over 4 weeks, measuring both PTSD severity, and the test again also measures individual PTSD symptomatology. Beginning directly after that 4th baseline was taken, the participant began 10 weeks of prolonged exposure therapy. Measurements were taken before the start of each session. After the last measurement, a discussion was taken about the patient's experience. And again, to reiterate, it was really important that we give the measurement right before any intervention was given. That way we can see, hey, what was the impact of that week, and that any sort of the insights or even psychological struggles or stress experienced during that session don't really skew the results in a meaningful way. Okay. And then in implementation of the intervention, let's go over I talked a little about what prolonged exposure therapy is, but this is kind of what it looks like, and there's a lot of different kind of ways to go over it, and this is how it is implemented in this session because there are some different structures to it, but this is what the norms seem to be. In session 1, you have collecting the information of the trauma, starting with beginning and end, developing treatment goals, and really it's about psychoeducation in this section. Session 2 involves in-depth discussion about common responses to trauma and further breathing retraining. Clinicians really explains what in vivo exposure is and helps to create a hierarchy for in vivo exposure. So this is before any in vivo exposure is done, you create this hierarchy of where you're most stressful, or you're from your least stressful to most stressful triggers, and like what do you want to address in the in vivo exposure. Then in session 3, you're reviewing homework related to psychoeducation, breathing retraining, in any homework that you would have had regarding uh, in vivo exposure, because after session 2, you do your first in vivo exposure, and then you begin the processing of imaginal exposure after explaining it, assign more homework. Sessions 4 to 9 involve, this is pretty consistent where you kind of get into a flow. It involves reviewing homework from breathing retraining and largely in vivo exposure. And then for the rest of the session, you focus on imaginal exposure and processing that experience. The last session, session 10 is termination. You review homework, you have imaginal exposure over the highest for like the entire trauma, you process it and you evaluate the treatment. And here is just an explanation after the homework. Again, you don't really the homework after session 2 is actually when you begin to confront it. The homework after session 1 is just the breathing retraining, and then after till termination, your homework is doing one form of in vivo exposure every time. Patients are also instructed to listen to audio of imaginal exposure. It only occurs after session 3 because session 3 is the first time you do any sort of imaginal exposure, and then it involves also the client practicing breathing retraining as well. To just go over replication real quick, I would say I would provide the treatment to another drone pilot. I would focus on these 4 individual symptoms, especially to see if there's consistency, because if a lot of studies start showing the impact, then you could kind of make conclusions for that, because this is one of the few studies that does it. I would again monitor the patient for 14 weeks, at least having that 4-week baseline, and administer the test or the measurement of the PCL5 after every session. And now we're on to interpreting the graphs. So the first graph shows overall PTSD severity. In this baseline here, you have this mean score of 59, so it's a really high PTSD severity score. And then you notice that it stays pretty consistent after the initial sessions. So this would be the first measure, and this would measure the impact after session 1. Still very high. Session 2, really high. In session 3, there's a noticeable spike. And it's worth noting that after the session, like directly after the session, the client stated how hard it was and how much he struggled, and there was noticeable discomfort and stress to the point where he's like, I might not come back next week. And so it was kind of interesting that it isn't like an insanely high spike because of how high his levels are, but it's a noticeable spike in terms of PTSD severity. And then the first drop comes after, this would be week 8, so after session 4. And then from session 4 to 5, there's another drop, and then it continues from there for overall PTSD severity. And this is what we kind of expected going into the research. And by the end, he held a score of 35 in the last week, which is pretty close to being below that threshold of 31 to 33, which states if you score above 31 to 33, you have PTSD and you also need to be treated for it. And so it's really interesting to notice the severe drop in overall PTSD severity score. So for the graphs of individual symptoms, I put difficulty sleeping and exaggerated blame together just to kind of show the difference. So for here, you have this baseline, it's around 3 and 4. For both difficulty sleeping and exaggerated self-blame, the first noticeable drop occurs in week 9, so that'd be after session 5. However, for difficulty sleeping, this doesn't seem to be caused by session 5 because you have this up, down, and by the end, he's back at 4, the level he kind of was. So there's really no noticeable change in overall sleep kind of based on that initial baseline. However, for exaggerated self-blame, after that week 5, he continues to drop continues to drop again, goes back up, and then drops back down to 2. And that's really interesting, especially because he had a lot of moral injury, so we weren't even sure going into it if prolonged exposure therapy would address like kind of the moral injury of the whole thing and the struggles with morality. But it seemed to have a pretty large impact and overall did decrease the score by the end, from that 3-4 range to 2 to 3. In unwanted memories and avoidance of stimuli, we put those together, or I put those together on the graph because you see it has that high baseline of 4 and so high initial severities. You have this initial drop off and going back up, but this seems to be somewhat random because it goes sharply back up. You don't really see a consistent drop until week 9, so that's session 5, and from there it consistently stays in the 3 range and goes to the 2 for unwanted memories. And for avoidance, you see the largest drop, which going into it, we did expect that, as we talked about. After session 4, it has the first noticeable drop and continues to go from there, spiking for a little bit and dropping all the way down to 1. That's kind of what we expected for avoidance because of the exposure nature of prolonged exposure therapy. And it was really interesting that unwanted memories also had this significant drop. We weren't sure, even though we were going over traumatic events, he had 10 years of experience. So there's a lot of unwanted memories associated with his experience, and so it was really interesting to see that noticeable drop. Now we can focus on challenges to internal validity and threats to internal validity. So the ethical challenges, again, don't think there's too many. There's a little concern of over-reliance. He also had this stressful outburst in session 3, but we talked about it and it was something we prepared for. And he has a history of military cultures related to not being honest about struggles. Just worth considering. Here's the main focus, and that's threats to internal validity. There's repeated testing. There's concern that with the week-by-week testing, there might be a little fatigue in regard to testing, and testing fatigue is a real concern to internal validity. And given that it's 14 weeks straight of the same test, there is concerns for that. There was also initially experimental mortality, which just dropout rate due to stress, and as well, the whole study kind of was predicated on Joe, and obviously it was for his benefit, but it would also impact us if he dropped out and impacts kind of the research and data we had. There's also the social desirability bias that I made sure to pay attention to. Joe has a deep respect for authority, so that was really important to consider, as well as, like I said, there's issues related to his disability benefits, so kind of just the social aspect of it we were worried about. And then history. He has a history of people pleasing, and we also thought there might be missing history of mental health disorders. Due to lack of healthcare access, all it said was he had insomnia before. That could just be a little misleading. Just having PTSD. PTSD is something that often shows up with other sort of mental health disorders, so we couldn't really control for that in terms of the results. Summary, conclusions, and recommendations. So, for overall, the research support our hypothesis that PE would lead to an overall decrease in PTSD symptoms or severity. So, in overall PTSD severity, it dropped from that 58 range and ended to 35 by the end of the treatment. So, it was a clear drop. And then for individual symptoms, there was noticeable reductions from the baseline in unwanted memories, trauma-related reminders, and I would say exaggerated self-blame as well, because it did get down to that 2 range by the end and had a little consistency there. However, for difficulty sleeping, there was no significant reduction. Like I said, it showed that up and down, but really by the end it had the 4, so there was no real reduction in PTSD symptoms as a result. In talking with Joe, he believed that the treatment was very helpful, and in noticing the drop in severity, we also believe that was really impactful in reducing overall severity and addressing those main symptoms, especially the symptom of trauma-related reminders and addressing that avoidance. He was able to really deal with a lot of the stimuli in our later sessions that we discussed that he would avoid in the past. And it's also worth noting in our conclusion, we think there was real significant and noticeable changes around session 4 and 5. And we think that's just important to note as future research develops on this topic. They might see similar results that session 4 and 5 are really what create that change and when you should start really seeing a shift in PTSD severity and changes in those overall symptoms. It's hard to say the exact sessions that might have led to decreases in individual symptoms, but in the symptoms that did change, sessions 4 and 5 are seen to be what sparked that. And right after is when you had that noticeable consistent drop. And it really wasn't noticeable in looking at the individual symptoms and overall severity that sessions later necessarily like caused more stress or like spiked PTSD severity or those symptoms. When there were spikes in individual symptoms later, they didn't stay consistent. And it was also the case that the spikes weren't really aggressively high in any of the symptoms. And so that's just worth noting and like kind of coming up with a conclusion. And so this leads me next to the recommendation portion. The client and I agreed that more research should be focused on drone pilots in particular. They're an under-researched population. I also believe they're underdiagnosed due to kind of the military belief that, hey, I didn't fight in battle, I don't need the help. So I think they're a population that's neglected. I also think prolonged exposure therapy needs more focus on the impact of individual symptoms and as well as focusing on the week-to-week impact. The PCL5, the week measurement, is new. It's objectively new. It's a newer measurement. So there's less data on the PCL5 and the week-to-week impact. And I think using that going forward in studies would really be beneficial into seeing, hey, what sessions should you start seeing that shift in PTSD severity? Is it consistent or is it on a case-by-case basis? Because based on this one single subject design, we can't generalize it and say sessions 4 and 5 is when you can see the drop. We would need a lot more studies, a lot more people. And so we really want bigger populations of probably ideally drone pilots seeing those week-to-week symptom change and see what you can expect. This will just help the clinician understand, like, hey, this is when I should expect to see a change. If I see continued worsening at this point, is this normal? Is there going to be spikes at certain points? And it will just give a clinicians a, a better understanding of how the sessions impact people week to week and also what to look for, what to be concerned for, what are like the warning signs. Hey, maybe this session, maybe it finds in other single subject designs that maybe sessions 8 and 9 actually cause spikes that didn't show here. And so that'll just be important to know for clinicians so they can make a more informed decision and not be panicked by high stress. Because as we mentioned, as I mentioned throughout the presentation, this is a very stressful form of therapy. It's very challenging. It forces you to challenge memories. It forces you to challenge triggers to your PTSD. So it's really important to kind of just focus on doing that week-to-week measurement and focusing on individual symptoms as well. Individual symptoms will be really beneficial, especially as it relates to sleep, because maybe this therapy doesn't help for that, and that also impacts, the doctor's decision on what medication to give to maybe focus on sleep. And then here's my references. Thank you for listening to the presentation. I hope you enjoyed.